Sepsis is the body's response to infection. Every neonate has a risk for it, and in fact, it's the third leading cause of death among neonates. Rule out sepsis is the most commonly ordered test for the clinical laboratory, and there's 1.75 million suspected cases in the US alone, of which over half of them are responsible for NICU admissions. I don't know how you react to this, but this particular picture evokes a visceral response because this is a tiny foot with multiple heel sticks, which is the state of the art for obtaining blood from neonates. Neonates, particularly very early neonates, have only a couple of tablespoons of blood, 30 milliliters. Their heels and feet are very fragile. Heel sticks can cause neuropathy and even can cause later in life neuropathy due to the admission of a baby in the neonatal unit. Persistent heel sticks can cause bruising, and it can also cause anemia as a consequence of the loss of blood. So what's the gold standard for rule out sepsis? It's blood culture. Blood culture requires a full 1 milliliter of blood to be taken, again, from a heel in order to obtain a sufficient volume of blood to do a blood culture. The heel sticks obviously are painful. Upon suspicion of sepsis, physicians will immediately administer antibiotics to these neonates. The blood culture takes between 2 and 3 days to get a result. The result can lead to the identification of an appropriate antibiotic that can be administered so that they can be switched off a broad-spectrum antibiotic regimen to one that's more specific. But unfortunately, the blood cultures have very high false negatives, and so physicians oftentimes do not trust the result of a blood culture and continue to administer antibiotics. So the bottom line is we don't want to give antibiotics unnecessarily to babies if they don't need it. There are alternatives. PCR, which we all know is a rapid but expensive test, and it also has a high false negative rate as a consequence of not having a full panel of microbes in the PCR panel. C-reactive protein is a generic inflammatory marker that can be used to measure the presence of general inflammation in the infants, but it typically needs to be measured in serial fashion, meaning it needs to be measured multiple times in order to see a rise in CRP, which gives physicians a suspicion of sepsis. So these are also both nonspecific, and they also require a blood sample. So what we'd like to do is remove the need for a blood sample. We'd like to have something that is acceptable to the nurses in the NICU and also acceptable to the parents of the neonate. And so we've examined the use of saliva as an alternative sample matrix for detecting a neonatal sepsis. Now, the problem with this is that the concentration of proteins in saliva is slightly lower than that in the bloodstream. But because the neonates have are still developing some of the proteins from the blood will leak into the saliva, so it's measurable. The problem, of course, is that at those lower concentrations, we need to have a more sensitive method, an analytically more sensitive method, but it still needs to have high clinical specificity, meaning we want to rule out sepsis and not administer antibiotics when we don't need them. And so we've developed a technology called Simoa, single molecule arrays, which has been commercialized by a company of which I'm the co-founder, called Quantx, that is an ultra-sensitive method for protein detection. So this method, as you can see from the green dots on the left, on the right-hand side, you can see that CRP, which is located on the left-hand side of the graph, we can measure that in many cases, but some cases it's undetectable as measured by the blue square. But most of the proteins that we're interested in measuring, we can't detect them using conventional technology. So this is an ultra-sensitive method that can access the concentration range of proteins that is undetectable using the conventional ELISA method. Now, there's other technologies that can be used that also can access this regime of ultra-sensitivity. The Quantx instrument is one that my lab uses just because we invented the technology, but it can be used with other technologies as well. We developed a biomarker panel of 12 biomarkers. We included a negative biomarker, and so what you can see is that every one of these biomarkers is elevated in septic infants. We did a huge clinical trial at 3 different clinical sites, Women's and Infants in Rhode Island, University of Florida, Gainesville, and also Tufts Medical, and consented 1,200 infants, measured multiple samples at multiple time points. So there's 2,800 samples, and we made 68,000 individual measurements of these different biomarkers. Now, one thing I can say about saliva in neonates is that it is an easily accessible fluid because you know babies drool. And so all you have to do is take a little Q-tip or an aspirate, and you can easily obtain sufficient sample quantity. We only use 10 microliters, less than a drop of saliva for this. So as you can see, there's complex data here, and so we need to develop a fingerprint for this biomarker panel. And that's done using the standard tools of artificial intelligence and machine learning that we can apply to this. And what we do when we apply this and develop models is we can develop a model, and this is just one of many models that we've developed, where in the upper left-hand quadrant, this is the correctly predicted negative sepsis. So we've ruled out sepsis in 75% of the cases with this particular model. That means we have the ability to avoid unnecessary antibiotic administration in 75% of the individuals. This is compared to the present system of blood culture, which is 20 to 40%. And so right now, our assay can rule out sepsis and prevent unnecessary antibiotics in over 1 million infants per year if we were to administer this. So here, there's a clear clinical need for this. It's the most ordered test in the NICU. It's the standard of care we know is slow and inaccurate. We have the ability to use this technology in low and middle income countries. We have already demonstrated 75% accuracy at 3 clinical sites in 1,200 infants. Clearly, there's a high commercial potential with both IP protection, a well-defined target product profile, and also there's minimal competition and a clear reimbursement pathway. So we're seeking funding either for developing this so that we can license this technology to an existing diagnostics company or spin out a company ourselves that can focus on this product. This is the team of clinicians. This is my team in the laboratory, and thank you very much.